Welcome back, and thank you for joining us for the second half of our Rocky Mountain 19th Annual Scientific Meeting. I would like to welcome Dr. Andrew Monte as our introductory speaker for our afternoon sessions. Dr. Monte is the Scientific Director with Rocky Mountain Poison and Drug Safety and the Medical Director of the Rocky Mountain Drug Center. He is also a Professor of Emergency Medicine and Medical Toxicology at the University of Colorado School of Medicine. Over to you, Dr. Monte.
Thank you so much, Kate. I'm really excited. Hopefully everybody got to get a little bit of a bite to eat and use the bathroom. This afternoon, we'll be spending most of our time here on psychedelic medications, as well as psychedelic drugs in the community. We have a wonderful lineup of speakers: Dr. Todd Korthus, Melissa Lavasani, who's the founder of Psychedelic Medicine Coalition. Yes, you get to see me one time here at the top. And then we also have Kate Reynolds, our research director that you've been hosted by here, Dr. Black, and Dr. Rockhill for the afternoon. So we're really excited to offer this session, and so we'll get going right now. So I'll start the afternoon by just talking about really the collaborations that we have across psychedelic monitoring. This is a mature mosaic for psychedelic monitoring that we are hoping to introduce and really talk through. Essentially, what you'll see is that we had a publication earlier this year that really talked about the rise of psilocybin use in the United States. This is a great example of a mosaic monitoring type of system where what you do is you start and you actually look at data points across multiple different data sources in order to triangulate things and see what the changes are. So, the figure on the upper left really talks about past year psilocybin use from our NMURX program. Now, of course, we've developed a newer program called NSIGHT that we'll be talking about here in a little while. But what you see here is that actually both young adults and older adults have actually had a rise in their psilocybin use. We then wanted to look at the adolescent population, and so we utilized the Monitoring the Future data set for that. And what you can see here is, whilst the confidence intervals are quite a bit wider, really what you see is the trend is actually rising for psilocybin use as well in that population. In order to get some concept around what the healthcare utilization was, we also examined the NPDS, or National Poison Data System analysis. And what you see in that data set is that you see an amazing rise actually in calls to the poison centers that are associated with psychedelic exposures. That doesn't necessarily mean that all these people had poor outcomes, and you really need to go through those systems in order to understand really the contexts of use. But really what all of these things showed us is that, yes, psilocybin use is increasing in the United States, and indeed, actually, we're seeing this across all age groups, and there's likely some increased healthcare contacts due to that. But really the key here is that all of the data sources are actually strong data sources. Now, there are limitations of each and every one, but in order to actually look at these things, you need to understand what the limitations of each of the data sources are in order to really understand where their limitations are. And really, that's one of the major take-home points here, is that all studies have limitations. You have to look at them and you have to understand where those limitations are, and then theoretically, you're able to try and actually design another study in order to fill those limitations. So we'll briefly talk about some of the limitations of current study designs. The clinical trials in psychedelics actually have been really quite positive. I think most people on this call would know actually about this clinical trial, the phase 3 clinical trial of MDMA for PTSD. Really what it showed is on the figure on the right here, is that there was a 30% effect size compared to placebo in these patients. That's actually a pretty profound difference, and actually better than most other treatments that we have for PTSD right now. However, when this study was brought to the FDA and this was put under review for possible approval, there were questions around the bias within the study. And in addition, the question was, how is this going to roll out in the general population outside of this controlled study population? And so ultimately, right, this was one of the contributing factors for actually this drug not being approved last year. Now, we all do believe that there's likely to be some benefit here of this drug, but the question is how do we look at the safety signals around it, and how do we actually make these types of trials generalizable in the general population? We know that cohort studies, while they're absolutely wonderful, they are inherently limited by who's in the cohort. And so when we think about perhaps the what's perceived to be the best cohort study ever, started really the Framingham Heart Study, there are actually limitations there. I went to high school about 2 towns away from Framingham, and I'll tell you that the people that live in that area are mostly white European descent. And that's what's going to happen here with other cohort studies as well. We're starting cohort studies, and actually our colleagues at OHSU are also starting cohort studies for psilocybin as well as other psychedelics. But, I'll say some of the only places that have a little bit even less diversity than does Framingham might be Colorado and Oregon. And so we have to think about what the changes are going to be in these other cohorts as well. And then actually hopefully expand and try and mitigate those by increasing enrollment and expanding across the country. Hospital records are notoriously biased and actually are limited by what's documented in the records. Many people like to use administrative data sets in order to examine problems, and yet they don't necessarily always think about where the issues are with those data sets. So we demonstrated this earlier in the paper that I mentioned, the Mosaic paper around psilocybin use, where we used the National Hospital Ambulatory Care Survey in order to look for psilocybin-related emergency department visits. When we did that, despite that amazing rise actually you saw in the NPDS data, actually there were only a couple, 3 cases of psilocybin poisoning in that data set between the entire 6 years. Now, this theoretically is our hospital records from the ED of 500 representative hospitals across the United States. Now, the problem there, however, is that there aren't great codes for psilocybin toxicity or adverse events in the hospital records. And really, you weren't getting into the records to say, okay, well, when people came in with altered mental status, was it associated with this? Or if they did come in, even within these 3 cases, was there some other reason why people were there? Were they intoxicated with something else? And that may be the case. So you're always limited by what is in there. I'll tell you, we saw this with cannabis in the past as well. When we looked at cannabis ICD codes, you pull in a whole bunch of them, but then ultimately only 26% of the ICD codes associated with cannabis are actually cannabis attributable emergency department visits. And so what is inevitable with hospital records and psilocybin as well as other psychedelics is we're going to see very little, and then all of a sudden people are going to start to document it, and you're going to see a massive rise in cases. That doesn't mean the cases weren't there before, and in fact, actually the NPDS data would suggest that actually there are cases there that are not being documented right now. It just simply means that people are starting to actually document it and maybe even talk about it a little bit more. When we think about surveys are a wonderful tool to get at the general population if, in fact, you actually survey the general population. Surveys that actually utilize platforms that go after focused groups that actually have opinions already may not be representative, of course, of the entire public. And so we see this when we see surveys administered on places like Reddit, or if we see this on forums that are actually advocacy groups, or people that are actually the surveys that are concerned with the safety of drugs. You're going to get the results within that from the people that are in those platforms. And so, one of the things that what we try to do is actually get at the general population so you can get an understanding of really use across the entire spectrum of people in the U.S., as well as understand the entire spectrum of use reasons. And so this is a wonderful example here of what happens if you don't do some of those corrections and you don't sample in the correct way, right? So this here is from our NMURX survey, and what this is psilocybin use. And so essentially, if you don't do any of the corrections, what you ultimately end up finding is that that's that top line there, where you don't actually control for any of the bias. However, if you actually get rid of the people that actually have careless response, so people that are just answering and not really sort of reading the questions very closely, like what we see in other surveys out there that don't do this, what we see is when we remove those, you actually get a decline in the rate and the prevalence of use there. Then you actually have to calibrate for the bias within the populations themselves, right? People generally say, oh yes, well, we're going to use a population survey that actually gets at everybody and it's generalizable. But there's always a difference between people that answer surveys and don't. And so you actually have to control for those things that are associated with people answering surveys or not. We know that in general, people that answer these surveys are actually a little bit less healthy, and in general, they actually have a slightly lower socioeconomic income. So in general, what you have to do is you have to control for those factors, as well as other factors, to really control for what the difference is between the people that are surveyed and who's actually in the general population. So when we do that final control for the difference of people that answer surveys versus not, you see that rate declines even more. Because again, if you just go after the people and you don't control for those things, and control for the reasons why people answer surveys, then what you're going to find is the rates are going to be much, much higher than they actually are in the true population. This is incredibly important work, and most places don't do this type of correction. And so you have to be aware of those limitations when you're looking at survey data. Really, combining data sources is what helps us mitigate the limitations of each of the sources themselves. The other thing is that you, of course, have to be very transparent about what the limitations of the surveys are. And so we're going to actually talk a lot today, and really the other people that are speaking this afternoon will be talking about the methods and really how they mitigate the bias within any of the data sets, because as I said at the outset, no study is perfect, but however, bringing things together, what you can do is you can be transparent about the limitations, and you could fill those limitations. So the National Survey Investigating Hallucinogenic Trends, or NSIGHT, is is really the largest survey of past year psychedelic use anywhere in the world. And so we're going to present some data here, and you're going to see some of those from a couple of our speakers a little bit later. Dr. Kerry Rockhill, as well as Kate Reynolds, will talk through some of this stuff. What is NSIGHT? As I said, NSIGHT is the largest ongoing adult psychedelic use survey in the US. And actually, by the end of this year, we've been running this survey now for 3 years, and actually we'll have the 2 full years of data by the end of 2025, and we'll have well over 8,000 respondents at that time. It's managed through an online panel that actually is the general population. So this means that you're not just getting people within state-regulated programs, you're not just getting people that are in the hospital getting ketamine, and you're also not just getting people that are using recreationally. You get the entire population. It really gets into detailed use patterns, very similar to the NMAOX survey, and you saw so much of those data earlier today. One of the really important things that we find really helps us actually with these with the reliability of the data are using validated scales. So these are scales that have been validated for in multiple populations, so that we can understand mental health symptoms. We can understand how people perceive their outcomes, their clinical outcomes, and we actually can get at perceived benefits in that way. This study is actually relied on by Colorado and Arizona and other states here as well. And it's funded by our colleagues at SAMHSA, who've just been wonderful in actually helping us bring this to the community. These data are important for our colleagues at SAMHSA, and I believe that they're important data that are not available in other places. We're actually able to capture multiple different psychedelics, and we can do stratifications across geographies, individual behaviors, individual medical use patterns. As I said, we can do this across geographies, even down to the individual state level. This figure actually shows any psychedelic use, so all 16 of the drugs are actually included within this, and we actually can do substratifications down to the individual state level, and down even eventually here to the 3-digit zip code level, so that you can understand how different counties are responding with specific substances such as psilocybin. Of course, in some of these, as you may see, the rate in Alaska is actually quite high here, but the confidence intervals are quite large because there's relatively fewer people in Alaska. However, as we stack these data together, just like National Survey of Drug Use and Health does, 2 years will actually give us really quite good estimates as well, and you'll be seeing those data coming up. I'm really excited to be able to actually introduce the annual data report of Insight. So you can see the website here on the screen, and we'll also have it in the chat. But what you can do is download this report, and really this is all the data from 2024. And of course, we'll be doing this every year. And really, actually, what you're able to find in this are some really interesting and wonderful cross stratifications of different substance use, as well as why people are using and really what their benefits are. So within these, as we start to subset these data in the table below that comes directly from the report, you can look at psilocybin use overall at 2.1%. However, you see it's much, much higher in ages 18 to 25. It doesn't seem to change much in ages 26 to 50. But then when you get ages 50 and above, you see that actually the use decreases pretty dramatically down to 1%. However, if you contrast that with MDMA, you actually see that the highest use is in that really younger age group of 18 to 25, and you see a much more rapid decline in use as people are older. And so as you can start to put these things together, you can understand that, okay, well, we need to actually message differently around MDMA and the medical use of these in different populations. And so we hope to be able to actually share these data going forward and actually be able to do additional stratifications as needed for our public health colleagues. I'll talk briefly about the Sentinel Poison Center program, which is really an enriched adverse detection system with a very detailed case granularity of the most severe cases, the ones that actually call poison centers across the country. So the Sentinel Poison Center program really is something that's relied on by multiple groups. And I will say that the NPDS data, the Poison Center data, are relied on by the FDA, although Sentinel Poison Center data is really where we go into the case notes and we really make sure that the fields that are coded are accurate. NPDS is a wonderful data system and actually does really good things, and you capture a lot of data. But it's the same data for absolutely every substance, from Clorox under your sink to SSRI to, unfortunately, psilocybin and mushrooms as well. The data that are needed for these different uses are actually quite a bit different. And unfortunately, sometimes what happens is because this is a national system, you get some misclassification. We've demonstrated in the past where oxycodone was actually coded as oxycodone in NPDS, but in reality, it was fentanyl when you go through the case notes. So it's really, really important to go through these things. And then in addition, what our call center does is actually takes additional information on set and setting that is not available in the NPDS data. They capture reasons for use, source, and dose. Now we're actually getting these data in Colorado, Oregon, Hawaii, Montana, and Nevada. And so we're actually really happy about this because we believe the data are really add something, and they tell a different story than what you saw initially with this massively rising slope of NPDS data. Really what you're seeing is actually the reasons for most of those visits were concomitant substance use. And so that's what I'll show here is from this data set. Really, more than 50% of these cases are psilocybin, as you might imagine here. It's the most common. Essentially, 52% of people report celebratory and recreational use, not the medical use that we're seeing now in many of these state-regulated programs. However, actually, if you look across Insight, what you'll see nationally is that almost 80% of psilocybin users are recreational use, despite all the discussion around the potential medical use. I think that what we have to do is understand that there is still this component of recreational use and not attribute the recreational use outcomes to the medical use population. And realistically, we have to tell that story in a different way, and that way we can mitigate the harm in both groups, really, if we understand that a little bit better. I'll briefly talk about the Oregon Psychedelic Evaluation Nexus, which is the longitudinal cohort study. Think about Framingham with this. And so really what Open does is it actually enrolls clients that go to these healing centers that are licensed in Oregon and now in Colorado as well. It captures data from the clients as well as the facilitators that are administering the care, and then essentially puts this data into a data repository and then has the capacity to bring data back to the participants as well as the facilitators. The wonderful thing here is that you start to actually get some triangulation of the people that are treating these clients as well. You know, the downside right now is that this does not enroll people outside of state-regulated programs, but it does have that capacity. It just takes quite a bit more work to do so. And Dr. Todd Korthus will talk about the details here and share some exciting data from this program here. We are really happy to be working with the OHSU group at Open in order to actually bring this into the Mosaic, because we think that this provides a nice longitudinal assessment of utilization. I should also note that this study was also funded by our SAMHSA colleagues and is a critical part of the Mosaic. So I will say that the safety and the clinical outcomes of psychedelic use, we're now trying to bring all these groups together under a center where we will have data that are available to the public. The SCOPE Center, Safety and Clinical Outcomes of Psychedelic Use. This is a collaboration between RMPDS and OHSU, and we actually have advisors from across the country, experts at places like CU, Stanford, Emory, the RAND Corporation for some of the survey work. And you can actually find out more information about this particular center and where the access to these data are at info@rmpds.org. These data will be utilized to actually support public health efforts as additional states move forward with legalization and liberalization of their psilocybin and other natural medicine policies. So what's next for these programs? We'll actually be working quite a bit on state estimates, state prevalence estimates of use. You know, that's something that we find is going to be really, really important. So understanding how there are changes in prevalence of use of psilocybin as well as MDMA over the coming years as these drugs are brought to the market under different frameworks. We hope for continuous enrollment through EnSite so that we actually can get seasonality of use. We've already documented that use seems to increase in the summer, as you might expect. We're expanding the Sentinel Poison Center program. As I said, now we're in Oregon, and we hope to be in the rest, many other states in the U.S. as we move forward. We're doing additional assessment of reasons of medical use and perceived effectiveness, because in general, as the states move forward with their regulated programs, this does actually expose other populations. And the question is okay, well, is psilocybin working for things like alcohol use disorder and in the general population? Right? Because you can run a clinical trial and keep a very close eye on people that are handpicked and chosen for a clinical trial, but it's a little bit different when you roll it out across all of Colorado. How are those people doing? Do the people that are using it for alcohol use disorder, for instance, in Colorado, do those approximate what's happening in the clinical trials or not? It can identify new populations that might actually have benefit. So really, we are continuing to work through this and get a good mosaic assessment of adverse events as well. We're seeing some signals here, and as I said, you saw what we had shown early from the NPDS data, where you saw a major uptick in calls to the Poison Center. But does that really mean there are so many adverse events? The answer is probably not, and it probably actually varies depending upon reasons for use, set and setting, as you heard earlier, as well as the legal frameworks in which these substances have been used. So this afternoon, what we're going to do is really focus on the data sources that are in this particular mosaic. We're going to focus on the methods so that the audience can really understand how these things work, and really also where the limitations are, so you know what you can utilize these things for and what you shouldn't, right? We're going to talk through and talk how we ensure the validity, because really the data going into a mosaic is really dependent upon the data sources, right? You have to understand how reliable those data are and what the validity are in order to understand whether or not they apply to the populations that you wish to apply them. And then what we'll do, hopefully, is talk a little bit about how the tools work together. I've outlined some of the areas where these things can work together, but really what we want to do is start to talk through how adverse events can be captured differently across these groups. How you get longitudinal follow-up in the open cohort, but maybe not in the Sentinel Poison Center group. What are the differences between the substances that are within them? How different are the demographics? Can you get durability? In general, Insight does a lot of these things, but what Open helps to support for us is some of the longitudinal follow-up, some of the more robust durability of effects. So you'll see that there are many different items here that we can triangulate across these tools, answer questions that might not be answered by one, but also actually have a unified set of outcomes across the tools so that we can tell a story that is triangulated. So I'm going to stop here, and I want to thank the audience, and we'll get going on a wonderful afternoon.
Thank you, Dr. Monte. It looks like we have time for one or two questions. The first one is, what can be done to improve the ICD case reporting in hospitals?
Yeah, it's a great question. I would say that first and foremost, there really only is one particular ICD code for psilocybin toxicity right now. So what is the definition of psilocybin toxicity? I mean, some people would actually say that if people end up in the emergency department with, altered mental status, that would be an evidence of toxicity. But that may not be the case, and in fact, actually, that is one of the things that the drug is supposed to do in order to facilitate, improvement of mental health. And so realistically, we actually have to add more granularity about those things. But I would say that actually for medical records and ICD codes are never going to be a very good way to monitor emergency department uses, because as what I said earlier, what you're going to have is nothing, and then all of a sudden you're going to start to have people coding symptoms as psilocybin toxicity, for instance, just because they're starting to actually ask about it and recognize it. So, really I would argue that as ICD codes start to rise and reports of ICD codes start to rise, really what that means is that it's starting to become a conversation in the community more than anything else. Docs are going to start to be asking about it.
Thank you, Dr. Monte.